All right, good afternoon, everyone. We are right at time, so we will get started and do our best to get you out right at time as well. Thank you for joining our webinar today on nutrition interventions for your primary care setting. My name is Rebecca Bally. I am a facilitation and improvement specialist with QCOR, and my job today is to help moderate. We'll be asking for your feedback throughout the presentation, and just to let you know, to reduce the feedback noise, everyone is and will remain on a global mute. However, we do have time set aside to address your questions, and the best way for you to submit your questions is here through the question pane. It might look a little bit differently, but you'll see on the right-hand side of your screen a little drop-down panel that'll say questions, and that is the place to input your questions at any time throughout the presentation. I will read them for our presenter at the very end, and we'll do our best to get through everything. If you have technical issues, that's also the place to submit your questions, and I'll help troubleshoot those for you. One of the questions we always get is whether or not the slides will be available, and yes, we are recording this webinar, and the recording along with the slides will be available and posted to the HealthInsight website probably in about a week or so. We'll also have some handouts that we'll be going through that will be linked on that website as well. One of the other pieces of technology for today, we have a poll later on, so be on the lookout for that, and we'll be asking for your feedback. And at the end of the webinar, we ask you to please complete a short 5-question post-webinar survey to help us on our improvement journey. So first, a quick introduction to HealthInsight. HealthInsight is the Quality Innovation Network and Quality Improvement Organization, QIO, serving Nevada, New Mexico, Utah, and Oregon. There are 14 QIOs that bring Medicare beneficiaries, providers, and communities together in data-driven initiatives that increase patient safety, make communities healthier, better coordinate post-hospital care, and improve clinical quality. QIO work is grounded in principles aligning with the goals of the Centers for Medicare and Medicaid Services, or CMS, quality strategy, which are to eliminate disparities, strengthen infrastructure and data systems, enable innovation, and foster learning organizations. So along with the 13 other regional QIOs, HealthInsight is leading healthcare quality improvement initiatives, including the Million Hearts Initiative work for the CMS program 5-year period. We work with providers across the spectrum to develop and apply strategies for delivering safer and more efficient care. And as you may have guessed, this webinar is part of the Learning and Action Network, or LAN, efforts under the CMS Project on Cardiac Health. And today we have a fantastic expert presenter to talk to you about your nutrition interventions, Carrie Beck. Carrie Beck is the lead program coordinator for the Adult Immunizations and Antibiotics Stewardship Projects at HealthInsight, Oregon. She holds an MPH in Public Health Nutrition from the University of Washington and is a registered dietitian nutritionist, completing this graduate level training at Oregon Health and Science University. Carrie has held several positions in the fields of public health, community nutrition, and health promotion and chronic disease prevention. Her most recent positions include a team member of the quality department at a coordinated care organization serving the Tri-County, Portland, Oregon area, and managing the WIC program in Clark County, Washington, under the umbrella on a federally qualified health center. So without further ado, I will turn things over into Carrie Beck's capable hands.
Thank you, Becca. I am forwarding the slides now. Great, thank you. Hello, everyone, and thanks so much for joining us today on our Million Hearts LAN series. I'm happy to be presenting to you today. We have 3 learning objectives for today's webinar. The first is that you will be able to understand the importance of screening for food insecurity as a part of any nutrition program. You will also be able to identify nutritional therapy recommendations, also known as medical nutrition therapy, that have strong clinical evidence. And the third is that we will be exploring strategies and resources to implement these recommendations and interventions in your primary care setting. And we have a
Carrie, you might click on the slides first and then advance with the arrow.
Thank you.
There you go.
All right. So you may have noticed in the advertisement for this webinar, we were calling out National Nutrition Month, which is this month, every year during the month of March. And I'd like to give a shout out to National Nutrition Month. The website on this screen and also at the end of the presentation is a nice place to go for free resources if you want to celebrate Nutrition Month with your patients or staff. There's a variety of different nutrition education, social media messages, and other fun stuff. So what I'd like to do now is outline the steps for the recommended model I will be proposing today. And these are in line with the 3 objectives that I just went over. The first step would be to implement a food insecurity screening and referral program for all patients in your primary care clinic. The second would be to provide healthy eating education and information to your patients. And the third is to refer to a registered dietitian nutritionist when appropriate. So first, start out with some basic information about food insecurity. This definition comes from the USDA, and it reads the food security being the limited or uncertain availability of nutritionally adequate and safe foods, or limited or uncertain ability to acquire this food in socially acceptable ways. So there's 3 terms that stick out here. Nutritious food, safe foods, and acquired in a socially acceptable way. Safe food, an example of that might be, does a household have a refrigerator to keep foods from spoiling? An example of a way of obtaining food that is not socially acceptable may be someone taking food out of a dumpster from behind a restaurant or, say, a grocery store. We know that lots of food is thrown out every day. A lot of this food may be very nutritious and safe, but of course taking food out of dumpsters would not be considered socially acceptable in our society today. So all those components matter. How does food insecurity affect our country? 12.7% of U.S. households in 2015 were considered food insecure. And I've also listed the rates for the 4 different states that are part of HealthInsight. And you can see that Oregon is quite a bit higher than the national average. That isn't a surprise to me. That number has been higher than the average for some time. And the reasons for that could be a whole nother webinar, but you might be able to think of reasons why that might be, and I know that's been a real focus in Oregon. And you'll see that Utah, this was a surprise to me, that their rate is lower than the national average, and I'm wondering why is that? So, and why is food insecurity important? If a person or a household is food insecure, it increases your likelihood of having a chronic disease. Of note for those diseases are type 2 diabetes, high blood pressure, heart disease, obesity. And it also increases psychological and behavioral health issues. Of note would be depression, and there is a wealth of research that shows that children food insecure, or children coming from food insecure households have increased struggles in school. So we have just one poll question for today, and I thought this would kick off our looking at food insecurity screenings. Does your organization currently screen patients for food insecurity? So we always do, we sometimes do, we don't, or I'm not really sure. So let's see.
Okay, so the poll is open, and I see lots of folks are participating. Thank you. We'll just give a couple more seconds and let people get through, and then I'll launch it so everyone can see. All right, we've got about 80% of folks participating, so I'm going to close the poll and share. So there you go. You should be seeing it now.
Great, let's see. So yes, sometimes 47%. That's great to see. We have some people saying yes, about the same number of people saying no, and a quarter of you are saying I don't know. So very interesting. Thank you. And there we go. So let's next talk about how you might implement food insecurity screening in your primary care setting. So first, how would you do that? So there are several different modules for food insecurity screenings, and the module that I'm proposing here and that many others have is a 2-question module that's been tested and validated, and includes the 2 questions in front of you with the responses being often true, sometimes true, or never true. And if the person or the head of a household answered often true or sometimes true to either one of the questions, they would be considered food insecure. And I would like to point out that in Oregon, we are currently developing measure specifications for a food insecurity screening measure. This is being led by our state public health agency, the Oregon Health Authority, in collaboration with the Oregon Food Bank, the Oregon Primary Care Association, and our coordinated care organization Metrics Technical Advisory Work Group. So the next part of the screening, of course, is for those who are considered food insecure, ensuring that you are supplying them with community resources that can help them with this problem. So here I've added some of the most common sources of food in your community. All 5 of these first 5 should be available in any community, in R, to my knowledge. You might see Meals on Wheels has been in the news a little bit recently in the new president's budget. So that's gotten some attention. I'm most familiar with, of course, the food banks in Oregon, and I'd just like to point out that we have some really innovative programs here in Oregon, including cooking classes that are taught at the food banks and on site at other locations. These are called Cooking Matters. It's a nationwide program under the under an anti-hunger organization called Share Our Strength. And these cooking classes help families shop for and cook meals on a budget, and it is a really great program. We also have gardening classes where families can plant their own foods and their own plots of land. So check out what your local food bank has to offer. I also just wanted to add under SNAP or food stamps, I listed the maximum 4-person household income. For a 4-person household, they would receive on average about $649 per month. So quite a good amount, although we all know you know, the hardships of living just off food stamp. But these are resources that you can offer to your patients. We've developed a handout the link will be available at the end of the presentation, where you can download and share that directly with your patients as a PDF. So here I want to talk about some implementation strategies for adding food insecurity screening to your primary care setting. One of the most important things to remember is that any clinic staff can screen or make the referrals, whether it's the front desk staff, the medical assistant, etc. But it's also important to ensure that the results of the screening are made available to the provider because of the increased link to poor health outcomes that we discussed on a previous slide. The results should be documented in your electronic health record in an agreed upon location so all staff know where to look. Give the community resources list to the patient and briefly discuss their action plan. It could be as simple as who will you contact and when. If you have the resources in the clinic, refer the client to a social worker, a community health worker, or someone else that can do a more complete follow-through. And again, if you have the resources, it's always best to connect the patient directly to the community resource if you can. Make the phone call, get on the website, etc. So as I mentioned earlier, Oregon is working on a food insecurity screening measure, and they have a nice document with some best practices listed, which the information on the slide comes from. They have noted that that it's important to record both the positive and negative responses of the screening, so you have an accurate and thorough record of the patient. And of course, these things can change from month to month, year to year, so we want a history of how the patient is doing. Pilot sites in Oregon have found improved response rates when the questionnaire was given out in a written form in a private space for the patient to fill out, as opposed to, for example, verbally or in a place where, like a waiting room maybe, that other people would have the potential to look over your shoulder. It seems to me the exam room might be, one of the best places for this. And you can see why this is important. This could be a very sensitive issue for a parent. The next point is that remember that the most important thing is that the referral or the connection to the resource is made, not necessarily that you and your clinic offer follow-up resources, especially potentially when you are just getting started. Think about just making the connection to the resource. So now that you've addressed your patient's access to food, now what? Now we can focus on healthy eating and behaviors. So for today's presentation, the chronic condition that I've decided to focus on is hypertension. So this is just an example of where nutritional therapy recommendations could be applied. I chose hypertension because this is such a common diagnosis, and there is really strong, valid, and reliable evidence for how nutritional factors affect hypertension. So this is a review, I'm sure, for everyone. Hypertension is the most preventative contributor to cardiovascular disease and death in the world. It leads to other serious medical problems. It's often referred to as a silent killer because so often there are no symptoms. And you can see here there are 4 main factors where hypertension is impacted by nutrition. Again, here's a review. Here's a definition, or excuse me, the categories for how hypertension is defined. So anyone with a blood pressure of over 120 over 80 would be considered pre-hypertensive or as having high blood pressure. And I'd like to point out that here I'm going to go over the nutrition recommendations for hypertension, and I'm only going to address the ones during this presentation that have strong clinical evidence and have been deemed a strong recommendation. There are a few other recommendations that have fair evidence I won't be presenting today. And then the recommendations are also categorized as imperative or conditional. Two of the recommendations I'll present today have been categorized as conditional, meaning that they define a specific situation or population, or that they apply to that situation or population. So here are the 5 recommendations that I'm going to go over fairly quickly, and these are the 5 recommendations that have strong clinical evidence as defined by the Academy of Nutrition and Dietetics. So the DASH diet, this has been around for quite some time. It's a common diet. It stands for Dietary Approaches to Stop Hypertension. It has strong and imperative evidence. The research shows that you would expect to see a reduction of 5 to 6 millimeters over 3 millimeters of a reduction in blood pressure compared to the typical American diet. Now, I had to do a little bit of research to figure out what this recommendation is deeming a typical American diet. I didn't get down to the very specifics of that, but I do know that they are looking at the typical American diet as being, in general, a high-fat diet that is low in fruits and vegetables. Since the typical American, on average, does not meet the recommendations for fruits and vegetables. Now, there are 2 components to this recommendation. The first one is just the diet itself, and the second one is doing the diet on a calorie-controlled restriction to focus on weight reduction, so it's more comprehensive. And you can see that you would expect a slightly bigger decrease in blood pressure than you would for just focusing on the diet itself. In general, the DASH diet recommends about 1,500 to 2,400 milligrams of sodium per day. It's important to know that even if your patient is taking a blood pressure medication, that they could still follow this diet and limit their sodium. And that piece I just talked about a minute ago, thinking about healthy weight and regular physical activity, that is a component of the DASH diet, and you would definitely want to talk with your provider about those components. So what are the recommended foods for the DASH diet, and what are those foods that someone should avoid or limit? You can see for recommended foods, these are pretty common dietary guidelines for everyone. Whole grains, fruits and vegetables, especially focusing on those that are brightly colored. Non-fat and low-fat dairy products, so for example, non-fat and 1% cow's milk. Lean meats like fish and chicken, other protein foods like nuts, beans, meat alternatives like tofu. Healthy fats and oils like unsaturated fats, including vegetable oils. Seeds and avocado fall into that category. And then a big kind of a well-known part of the DASH diet are herbs and spices to add flavor. And what are the foods that someone following this diet should limit? This is not a comprehensive list. This is just a snapshot of that. Refined carbohydrates, saturated and hydrogenated or trans fats, which are have been quickly coming out of the American grocery shelves in restaurants, but still remain, those trans fats. High sodium foods, some examples are canned pickled vegetables, smoked meat, sauces like soy sauce and other sauces, and alcohol. So next we're going to talk about sodium, and you might think we just addressed sodium, and we did as a component of the DASH diet, but the recommendations have there is a separate recommendation where we look at where the research has looked at just a reduction in sodium as an individual component. So here, again, the evidence is strong and imperative. The recommendation is it's 1,500 to 2,000 milligrams per day. The research shows that you would expect an average decrease of up to 12 milligrams, or excuse me, 12 and 6 for blood pressure, which is quite significant. And here I have listed what I think are kind of the four important components of advice you would give someone or tips to lower sodium. Of course, there's a lot that can go into these, but important to talk to your patient about food labels and really pay attention to those serving sizes. We know those can be tricky. Manufacturers have a way of altering the serving sizes to make it look like the sodium or the sugar are less than they really are when normally one eats maybe the entire bottle or package. So pay attention to those. Most of our sodium comes from salt, and so really avoid salting food at the table. Use salt when cooking, but be careful of how much. And then eating out, boy, that's a tricky one. And encourage your patients to ask questions to the server, ask for nutrition labels, ask for alternatives to what is available as part of the meal. Next, calcium supplements. So this is a strong evidence but conditional. So the recommendation for supplements is only if your patient is unable to meet the recommendation for calcium with food alone. So that should be assessed first. And the dietary recommendation is 800 to 1,200 milligrams per day. The supplement recommendation is slightly higher. And the reductions you would expect to see are smaller than what we have talked about in the past, but still there is strong evidence to support this recommendation. There we go, a little bit of a lag with turning slides. The next recommendation is physical activity. So this recommendation has strong imperative evidence, and the recommendation is that your patient would get regular aerobic activity, moderate to vigorous in intensity, 3 to 4 times per week, an average of 40 minutes per session. So quite extensive. You can see the research showing what you would expect as a decrease in blood pressure. Lastly, we are going to look at the recommendation of alcohol intake in heavy drinkers. So again, this is strong but conditional evidence because it doesn't apply to those who are not drinkers, but the population who are drinkers. The first question, of course, is what is who is considered a heavy drinker? The definition is binge drinking on 5 or more days in the past month. That is a definition, or the definition that is used is from the group Substance Abuse and Mental Health Services Administration, SAMHSA for short. And then the next question is, well, what is binge drinking? I did look up binge drinking, and one of the definitions comes from the National Institute of Alcohol Abuse and Alcoholism, and the second comes from SAMHSA. If you have any questions about that, just contact me and I'll give you more information about that. The recommendation here is abstinence, and it's interesting. When I was giving a practice run for this presentation, one of my coworkers said, wow, that's a difficult recommendation for people who are heavy drinkers. That is, of course. And I think what's also interesting to know is that the recommendation for abstinence for moderate drinkers is weak. So the evidence shows only for heavy drinkers. And then the third thing to point out is take a note of the expected decrease in blood pressure. Wow, I was surprised. I guess I had not looked up this closely in the past. That is a very large reduction in blood pressure, so very significant. So how would you implement what we have just talked about in your primary care setting? How would you implement giving nutritional therapy recommendations to your patients in the primary care setting? So these are kind of split out into kind of 2 categories. One is advising your patients on healthy eating and giving some brief education, and then ensuring that you're giving your patient no more than 2 education handouts. Of course, first asking them if they're interested in them, but offering those to your patients. The second piece is, based on the condition that you're looking at, refer your patients to a registered dietitian nutritionist. And if you don't have a dietitian on site, refer outside of your clinic. And then also consider adding a dietitian to your healthcare team. We have had, this is becoming more and more common and popular around the country. Oregon has some really successful examples going on in the state of Oregon, including Yakima Valley Farm Workers Clinic has done an excellent job with incorporating dietitians at all of their primary care sites. I know that Mosaic Medical has a dietitian that rotates to several different sites. I know that some clinics around the state are experimenting with using dietetic interns from their local dietetic internships at universities. So if you are interested in getting more information about that, I can connect you to those who have experience in this model. So this is a slide that really combines looking at food insecurity screenings and medical nutrition therapy into one. What are some best practices for your healthcare team in making these changes? Whether you're starting with food insecurity or you've moved beyond there and thinking about medical nutrition therapy. So working on enhanced communication among your healthcare team is a really important piece of this. The American Medical Association suggests or recommends daily huddles and regular meetings. They also suggest increasing communication through what they call co-location. And this is a kind of a new concept to me. I've seen it in some different clinics that I've visited. But the definition for this is, or excuse me, the language that the AMA uses on their website is teams that sit in closer proximity communicate with greater frequency and ease. Questions can rapidly be answered, reducing the time that someone may have to wait before completing a task or responding to a patient. Everyone will be aware of the work that their teammates are doing, enabling easier task sharing and division of work. I saw a really great example at a clinic in Portland called Wallace Medical Concern when I was at a previous job. Don't forget to train your staff for these new skill sets that you are working with them on. Use the technique that we hear about a lot, motivational interviewing, and teach back technique. Now, if teach back is new to you, this is a research-based health literacy intervention that promotes adherence, quality, and patient safety. It involves asking the patient to explain in their own words what they need to know or do. It is a way for checking for understanding, and if needed, re-explain and check again. Moving on, look at your workflows. Design the workflow to insert a food insecurity screening or a medical nutrition therapy implementation into your workflow, or edit an existing workflow. Think about long-term planning and follow-up for your patient. The next one is all about documentation, and in your EHR, we talked a little bit about that today. And it's important to stress that the information is documented in the same place, and use your policies and procedures to help make that happen. And lastly, consult us. Consult your quality improvement organization, your QIO, for assistance with any of these best practices that I have talked about. And for the 4 states that we're talking to right now, that would be your HealthInsight organization. So you might be thinking, okay, I'm kind of interested in what a dietitian does. How do I find a dietitian? So there is a nice free resource on the Academy of Nutrition and Dietetics website. Right at their main site, eatright.org, you can click on Find an Expert, and then it takes you to the page where you can enter your zip code. You can also filter it by searching by expertise, and some of the expertise categories that are listed are diabetes, heart health, weight control. There's a host of others, but those might be ones that you might want to check. Waiting for this slide to go. There we go. I hope it doesn't advance one more. And then this is a screenshot of an example of what you might find. So I've put in an area in Central Oregon. I see some dietitians listed. You see the filters that I've applied. And if you click on View Details for a dietitian, the dietitian has agreed to list their direct contact information. Also in this, under View Details, you would be able to see their languages spoken, and also whether they have experience in group consultation, individual consultation, and any programs or workshops. Now, dietitians on here are listed that are available for consultant work and contract work, but also dietitians that are associated with an organization. So you'll want to take note of that. So I just wanted to give a little bit more information about, about what you can expect from a dietitian. Dietitians have an approach called the nutrition care process, and this is our systematic approach for ensuring that every patient is provided high quality nutrition care. The steps that a dietitian goes through would be a thorough assessment, diagnosis using standardized diagnostic statements that are specific for dietitians, but we also use coding that other providers do. The next would be nutrition intervention. Part of that is, of course, diet and lifestyle recommendations. Goal setting is an important piece of that, and patient education materials is a component of that. And then thinking about monitoring your patient, thinking about reassessment and follow-up. This is a busy slide, I know, and I'm not going to go through it bullet by bullet. I wanted to just give you some basic information about what is the coverage for medical nutrition therapy. That's the name that's the official name for insurance purposes for Medicare and Medicaid. So for Medicare, there is a specific coverage for beneficiaries with diabetes or renal disease. There's also coverage for diabetes self-management training, which a component of that is healthy eating. So that is a component of it. And the DSMT is a distinct, separate benefit from the medical nutrition therapy benefit for that is in the bullet point above it. Medicaid is a whole new ball game. There really is the coverage for Medicaid varies widely in terms of what state you're in and what insurance company you are going through. I have a little bit of experience in working with a coordinated care organization and other CCOs in Oregon, and I know firsthand that several CCOs, if not many in Oregon, cover several or unlimited visits for your patients to see a dietitian. And I would encourage you all who are interested, both primary care settings and dietitians, to contact your insurance company or coordinated care organization or accountable care organization, which is similar to a CCO but outside of Oregon, to discuss what services you have to offer and negotiate benefits for your patients. Oftentimes these can be negotiable and there is room to sell yourself and sell the health of your patient. I didn't put in here, but I was thinking about this morning, Medicare Advantage plans that are often run through ACOs, CCOs, and insurance companies. And again, the coverage varies, and I encourage you to discuss that coverage to talk about the benefit. Aha, another very busy slide. This slide has to do with all of this work and Medicare around the Equality Payment Program. And part of the QPP is MIPS. MIPS stands for Merit-Based Incentive Payment Program. And part of it is that clinics like yourself can do quality improvement activities and get credit for those. My coworker did a brief search on nutrition and food for MIPS activities, and this is what came up. So interestingly enough, Screening for food security came up. Now this is part of a QCDR, which I am not that knowledgeable about, but we can certainly help you here at HealthInsight to decode that a little bit. And the second one is about capturing information in an EHR for certain things like food diaries and alcohol use, which could be a part of a nutrition assessment. So keep those in mind, and if you're interested, please give us a call or send us an email. We'll help you figure that out. All right, so boy, that went quick. What have we covered here today? We've covered the importance of screening for food insecurity, which is really the most important step, because it's very difficult to talk to a patient, as most of you know, about healthy eating if they don't have access to nutritious and safe food that they can obtain. Providing the screening and providing the referral. Provide basic healthy eating education for your patients with hypertension and other chronic conditions. Refer to a registered dietitian nutritionist. Communicate with your healthcare team to make these processes work, and have resources at your fingertips. I included some healthy eating resources on a few slides, partly because when all of you registered, we asked the question, what would you like to get out of this webinar? And several of you said that you'd like some basic resources for healthy eating and general nutrition guidelines. So number one, I've included the National Nutrition Month website here. Actually, I'm gonna skip back to patient education handouts, but before I go there, I'd like to call out Food Hero. What a wonderful resource this is. It's developed by Oregon State University Extension Service. It's really one of the best I've seen. It's available, everything on it, including recipes, are available in English and Spanish, and it focuses on quick, tasty, and healthy recipes. Check it out. Of course, the Dietary Guidelines for Americans. This is a wonderful resource. My Plate. We've all seen this for a little while now. My Plate is another really extensive website which has so much information I can't even sort of begin to start telling you what's there. There's a great food and activity tracker. You can see food plans. Anyways, in personalization, they allow for personalization in there too. I want to point out one more. There we go. Here's the website for that talks about food labels. On the left side is what our food labels are looking like right now. On the right side is what they're going to look like soon. Did I write down the date? As you know, we're going to be seeing a change in food labels. So some really good information about working with your clients on the changes, or how to read a food label and the differences. And I'm going to make this difficult and go back a couple. So I've also did a little bit of work thinking about what are the patient education handouts that I would recommend. Two of these focus on the food insecurity piece. So the community resources handout here is developed from the slide that we went over earlier. The Oregon Food Bank has a real nice 3-page handout. They call Healthy Food on a Budget. It has implementation strategies for the food insecurity screening. It has the questions that you would ask, and then the 3rd page is also a list of community resources for food. For the DASH diet, I have a handout that is from National Institutes of Health, which I think does a very good job explaining it. And then the fourth one here is a front and back handout on reducing sodium. I really like. It's colorful and easy to read and a low literacy. So for the community resources handout and the sodium handout, we have a website there. Those are not quite up yet, but will be soon. I think we're about done. And it's time for questions. I'm going to turn it back over to our facilitator, Rebecca.
Great. Thank you so much, Carrie. There was a lot of rich information that you presented, and I know we went through it fairly quickly, and there are several questions. I did want to say, too, I posted a question in the question pane for the audience and got a couple of responses about what other clinics are doing to screen for food insecurity. So check that out in your questions pane, some examples of what this looks like. So Carrie, a question came in about the DASH diet, and specifically, why does the DASH diet not have the same sodium restrictions listed under the sodium restriction recommendation, and how is there a greater decrease in blood pressure just by reducing sodium versus following the DASH diet?
Very good question. I actually was thinking about this last night. I did a little research and did not find the answer to that. There might be other dietitians on here, which I'll ask to chime in. One of my thoughts is that you might be expected to see more of a decrease in hypertension with just the sodium diet versus DASH, because potentially the sodium diet may be easier to adopt because it's focused on one intervention rather than a component of interventions. So the other piece about why is the sodium restrictions different in each of those diets? To be very honest, I don't know the answer to that, and I'm just wondering, I think we might have the time. Are there any dietitians out there that have the answer to that, or other professionals that want to chime in? Raise your hand if you know the answer.
I'm not seeing any brave souls yet.
Not seeing any. Okay. I'm going to do a little bit more digging, and I appreciate that question, though, and we'll do some research into that.
And we have your email, so that question came from Amber Hain, and we can follow up with you after the webinar once we get more information. Is that all right with you, Carrie?
Yes, absolutely.
Okay. We actually had several questions about this, and I know you touched on it briefly in your implementation section, but there are a lot of folks wondering how to integrate registered dietitians into the primary care team. Are there models of what this looks like? I've seen models where this looks like, but I'm wondering if you could speak more to that from an example and an implementation standpoint for folks.
Sure. Was that directed at me, correct, Rebecca?
Yes. Yes.
Yes, there are some implementation models. They haven't been around for very long because dietitians have not been in the primary care setting for that long. We've typically been in hospitals and food service and WIC, but that's changing. And the professional association that represents dietitians has a toolkit and other resources that are available, which if you are interested, I could send those to you. The other I think, important piece of this is those who have successfully done the integration, talking with them. I know I talked with a colleague this morning who was the former supervisor, nutrition supervisor at Yakima Valley. She's now at Care Oregon. I hope she's okay with me saying this. And she said she would be happy to consult with clinics who are interested in this and moving forward with this work. So, and then the third piece I would say is, and I'm trying to think fast about what kind of lessons I've learned with working on these projects in the past. Really, you know, a dietitian should, if you're going to successfully do this, successfully integrate a dietitian into the primary care team, they need to be a part of the huddles, the meetings. The team needs to know, needs to be aware of what they specialize in, what they can provide, and there are lots of different ways to do that. And gosh, all these, I'm trying to think fast about this, but I think the best thing is that sharing the toolkits and the resources that I have, maybe having a follow-up call with clinics that are interested in talking, making connections to you, to those experts who have a lot more knowledge on this, and I think those would be, you know, two of the best ways to move forward, thinking about how to successfully implement this kind of a program. And if others are on the call that want to chime in, feel free.
Thank you. We had an example shared. There's a patient-centered primary care home in Oregon that has a great process for using registered dietitians in their clinics, and they also use students as extenders in their clinics, and they're supervised by the registered dietitian on site, so they get more of a broad reach. And I wanted to just say, too, that we've been giving a lot of Oregon examples. I know there are a lot of Oregon folks on the call. But you have resources in your state. If you're from Nevada, New Mexico, or Utah on the call today, there are folks that you can connect with, especially to talk to you about some of these examples and figure out what's working in your state if you need some more localized examples. And
Becca, could we share the two examples in the chat from Akira and Megan? Or maybe everyone?
Yeah, they are shared there. People should be able to see them in your question pane.
Okay, thanks you guys for sharing. That is great information.
Yeah, and if you have a great example from your state or from your clinic, please feel free to share that as well while we're going through. We don't have any other questions at this time, so I'm going to go over a couple of final slides, but if you think of something before we're done, please do chat it in and we'll see if we can squeeze it in. So this is a reminder about how you can submit your questions, so if you need that. And then thank you, Carrie, so much for doing all this research and putting this together, lending us your expertise, and providing all these fantastic references. Again, a reminder that the slides will be posted on the HealthInsight website, so you can access all of these resources and click on the links and take a look at what's available for you. Here is our presenter's information if you need to get a hold of her. Again, we also have your contact information, so if we said we were going to follow up, we can do that. And actually, I'm going to let Carrie also speak to this one. There's a new project initiative that HealthInsight is helping to support, and Carrie's the lead of it, so I'll let her give a very, very one-minute brief explanation about it.
Yes, I will just say that we would love to have your support in this project for antibiotic stewardship. It's open to all outpatient settings, so that would mainly just exclude hospitals and nursing homes, but all of the other outpatient settings that want to pledge their support and work with us on implementing these core elements of outpatient antibiotic stewardship. We have a host of examples of ways that you can fairly easily move this work forward. We all know how important it is. So we will be able to provide you with an assessment, free technical assistance, patient education materials, and a host of other things that we as QIOs provide. So I encourage you, I'd love for you to visit our website today or soon, and you can actually sign up directly on the website using your mouse and pledging your support, and we will be in touch with you to move the work forward very soon. Thank you.
Perfect. Thank you so much, Carrie. And thank you, everyone, for joining us this afternoon. I know you're very busy, and this is probably your lunch hour, so thank you for joining us. Please do complete our very quick 5-question post-webinar survey. Tell us how we did. And our next webinar, for those of you who are following our series, will be on Monday, April 10th on health behavior change, practical approach to improving patient engagement, so very relevant to some of the things we talked about here today. And otherwise, I hope you have a great rest of your Tuesday and a great rest of your week. Thanks so much.